Hello guys, my name is Anesuishe Blessings Gatsi. Welcome to my channel. Don't forget to like, comment, and subscribe. So getting straight into the video in focus, which is looking at the brainstem. This is going to be our brainstem, composed of the medulla, which is about 3 centimeters, and it's actually continuous with the spinal cord in the region of the foramen magnum. Then you're going to have the pons, which is this one. It's going to be about 2.5 centimeters. Then you're then going to have the midbrain, right? And embryologically, the brainstem will actually be derived from the neural tube. Remember how you're going to have appearance of 3 primary brain vesicles on the cranial end of your tube. And those were going to be the prosencephalon, your forebrain, then the midbrain, which is going to be the mesencephalon, then the hindbrain, which is actually going to be your rhombencephalon. Then from those primary brain vesicles, you're going to have formation of secondary brain vesicles. From the prosencephalon, you're going to form the telencephalon and the diencephalon. Then the mesencephalon was going to persist as a mesencephalon. It was not going to form any secondary brain vesicles, and so it is going to form your midbrain. And the lumen of that mesencephalon to actually persist or remain as the cerebral aqueduct, which will actually join the third ventricle that is being formed from the lumen of the diencephalon to the fourth ventricle. Then your rhombencephalon will then be divided into a superior or a more rostral metencephalon, then a caudal myelencephalon. The myelencephalon will form the medulla, whilst the metencephalon will form the pons. And it's also going to form the cerebellar plates, which are going to form the cerebellum, which from this picture are these two structures here, your cerebellar hemispheres. So if you appreciate it from this lateral view, this is the midbrain. Notice it's the shortest of all the 3 segments of the brainstem. And you're going to have this pregnant lady, which is your pons, that is about 2.5 centimeters. Then you then have the medulla, right? And this is actually the fourth ventricle in this region, being bordered by the brainstem and the cerebellum. That is, for the brainstem, you're looking at the pons as well as your medulla, right? So we'll start mainly with the external surfaces of the medulla, right? So this is your medulla, right? And the medulla in the midline, you're going to have a ventral median sulcus, which is this one, right? And this ventral median sulcus, in its lower end or the caudal ends of this ventral median sulcus of the medulla, they're actually obscured by the decussation of the pyramids, which is actually occurring in this region. Remember, 85% of the descending corticospinal fibers will actually decussate in this region. Right? So these will be the pyramids, right? Separated by the ventral median sulcus. Then lateral to the pyramids, you'd expect to have the olives, right? Then just lateral to the olives, you then expect to have the inferior cerebellar peduncle, right? And from the medulla, you'd expect to have emergence of cranial nerves. In this case, between the pyramid and the olives, you're having the hypoglossal nerve, which is actually cranial nerve number 12, going to innervate the muscles of the tongue, right? Then between the olive and the inferior cerebellar peduncle, you'd expect to have in this order cranial nerve number 9, number 10, and number 11, particularly the cranial root of that accessory nerve. Because remember, the spinal root will actually be coming from C1 to C5 spinal cord, cervical or spinal cord segments. And it's going to pass through the foramen magnum to come and join the cranial root to form the accessory nerve itself before it actually exits the skull in your jugular foramen, together with, of course, the 9th and the 10th cranial nerves, right? Then this is then your pontomedullary sulcus, which is the rostromost limit of the medulla. And from this pontomedullary sulcus, you'd expect emergence of cranial nerve 6, which is this one, your abducens nerve. Then you have emergence of cranial nerve 7 by 2 roots. A more medial, which is the motor root. Then a more lateral, which is your nervus intermedius. Then more laterally, you have cranial nerve number 8, which is your vestibulocochlear nerve, actually carrying fibers that are coming from the ear. The cochlear division will be carrying the fibers that are coming from the organ of Corti. Then the vestibular division will be carrying the fibers that are coming from the utricle, the psyche, as well as your semicircular ducts, which are actually responsible for balance. Of course, the utricle and the psyche, that is the linear motion. Then the semicircular ducts, that's now for the rotational motion, right? And if you look at the ventral aspect, of the pons, there is actually a sulcus. It's actually grooved by this basilar sulcus. Within this basilar sulcus, you'd expect to have the basilar artery, right? The basilar artery will actually be formed as a result of the union of the two vertebral arteries, which are coming from the first parts of your subclavian arteries, right? Then this is your midbrain, and the midbrain, its rostral most limit will actually be marked by these mammillary bodies, which are parts of your hypothalamus. And separating, of course, the two ventralmost parts of the midbrain, you'd expect to have this interpeduncular fossa, right? And this interpeduncular fossa, in its flow, you'd expect to see the posterior perforated substance, because it's actually going to be perforated by vessels, right? And just lateral to this interpeduncular fossa, you have emergence of the oculomotor nerve, which is this one, that is going to supply most of the extraocular muscles, except your lateral rectus, which is being innervated, of course, by the abducens nerve, which is coming from the pontomedullary sulcus. Then the superior oblique will be innervated by the cranial nerve number 4, which is your trochlear nerve, which is the only cranial nerve that actually emerges on the dorsal aspect of the brainstem. It will actually be emerging on the dorsal aspect of your midbrain. We'll see it from a more dorsal view, right? So this is still the same thing that we were describing, just that we are now looking at a more proper brain section. So this is your medulla, right? This is your anterior median fissure. Then these are the pyramids. Then you'd expect to have the olives in this region, right? And notice in the junction between the pyramid and the olive, that's where you have the hypoglossal nerve. Then all the other nerves, they're coming from there, right? And those nerves can actually be compressed by a tumor that extends into the cerebellopontine angle. For example, if you have a vestibular schwannoma that actually extends to the region of the cerebellopontine angle, it can actually compress on the glossopharyngeal nerve and the vagus nerve as well, resulting in a hoarseness of the voice, right? Then this is the abducens, this is the facial, the motor root, then this is the intermediate nerve, your nervus intermedius, right? Then this is the vestibulocochlear nerve, cranial nerve number 8. Then emerging from the lateral ends of the pons, this is the trigeminal nerve, right? Then this is your oculomotor nerve. And going more superior, you notice the presence of the mammillary bodies. Then you have the optic chiasma, then you have the optic nerves. So the optic nerve and the olfactory nerves, they're the only two cranial nerves which are not actually attached to the brainstem. The rest of the 10 cranial nerves, they're attached to the brainstem, right? Then this is a dorsal view. This is a dorsal view of the brainstem, right? From this region, we can appreciate the presence of the dorsal median sulcus, which is this one, right? Then just lateral to this dorsal median sulcus, you'd expect to have the gracile fasciculus, which is this one, right? This gracile fasciculus, just lateral to it, you also have the cuneate fasciculus. If you remember the dorsal columns of the spinal cord, you're going to have these two fibers. The gracile fasciculus, of course, carrying fibers from the lower limbs, then the cuneate fasciculus carrying fibers from the upper trunk. Right. Then lateral to this cuneate fasciculus. So these two, they'll actually cause the tubercles. That is your gracile tubercle and the cuneate tubercle, these elevations that you actually appreciate on the dorsal aspect of the medulla, right? Then just lateral to that, you'd expect to see the tuberculum cinereum, which is this part here. So this is your tuberculum cinereum, and this tuberculum cinereum, it actually marks the position of the trigeminal spinal tract and its nucleus, right? Then notice in this region here, you have the vestibulocochlear nerve, right? So these are the peduncles, the superior cerebellar peduncle, the midcerebellar peduncle, and the inferior cerebellar peduncle. The inferior cerebellar peduncle, when you then look at the auditory pathway, it's going to separate the ventral cochlear nucleus and the dorsal cochlear nucleus, right? That will be subserving audition, right? Then from this view, these are the nerves that are exiting from the lateral ends of the medulla, the glossopharyngeal nerve, the vagus nerve, and this is the accessory nerve, its cranial root actually being joined by the spinal root, which is coming from cervical spinal segments C1 to C5, right? Then due to the fact that when you're actually dissecting specimens, if you then remove the cerebellum, you're also more likely going to remove the thin roof of the fourth ventricle, and you're going to expose its floor in this region, which you then refer to as the rhomboid fossa, right? Which is dark gray in this schematic, right? So notice this is the medial sulcus, right? So this medial sulcus, right? It's going to separate it into two halves, right? Then you're going to have the sulcus limitans, and this sulcus limitans will further divide those two halves into a medial facial colliculus being formed due to the underlying facial nucleus of the facial nerve. Then laterally, you have the area vestibuli, which is being formed as a result of the underlying vestibular nuclei. You're going to have a superior, a medial, a lateral, and an inferior. Of those four, you'd expect to see the superior vestibular nucleus actually in the pons, then the rest, they are found within the medulla, right? Then actually passing through or bisecting this median sulcus, you have this stria medullae, right? The stria medullae will actually be carrying fibers that are coming from a nucleus known as the arcuate nucleus, that is more or less a displaced pontine nuclei, which has connections to the cerebellum. Some of the fibers that actually come from that arcuate nucleus, they will use your external arcuate fibers that will actually be going to the cerebellum, right? Some of them will then use this stria medullaris that will be entering the cerebellum via the inferior cerebellar peduncles. Because remember, the medulla will be attached to the cerebellum via your inferior cerebellar peduncle, then the pons via the middle, then the midbrain via your superior cerebellar peduncle. Right. Then in the lower regions, there is the presence of this hypoglossal trigon as a result of the underlying hypoglossal nucleus. Then you have the vagal trigon in this region, right? Due to the rostral ends of your dorsal nucleus of the vagus, as well as your NTS, which is your nucleus tractus solitarius, right? Then also in this region, you'd expect to see the area postrema, which is this one, right? The area postrema will actually also represent part of your circumventricular organs, which are associated with the fourth ventricle, right? Those circumventricular organs, they'll actually be lacking a blood-brain barrier, right? Some of them, you find them associated with the third ventricle. For example, your OVLT, right? Then this is going to be your superior medullary velum in this region. This V-shaped region here. This is your superior medullary velum. And the superior medullary velum, it's simply a thin white sheet of matter that is going to separate, it's actually going to separate your peduncles now. Notice in this region. So this is the superior medullary velum, right? This is actually intervening between the peduncles that are going to be converging in that region, right? Then you'd also expect to have a more thinner inferior medullary velum. And within that inferior medullary velum, that's where you expect to see the median aperture, which is your foramen magendi, that will allow for communication now between the fourth ventricle and the arachnoid space for you to actually drain cerebrospinal fluid into the arachnoid spaces. Remember, you're going to have a median foramen of magendi. Then you're going to have two laterally placed lateral apertures that are going to be your foramen luschka that you're going to find within the cerebellopontine angle, right? Then from the region of the midbrain, you can notice the emergence of the trochlear nerve, which earlier on I said is the only cranial nerve which actually emerges on the dorsal surface of the brainstem, right? Then you see the bulges of the tectum, your corpora quadrigemina, the superior colliculi, which subserve vision, then the inferior colliculi, which subserve audition. The inferior colliculi, via the inferior brachium, which is this one, they will attach to the medial geniculate body of the thalamus. Then your superior colliculi, via the superior brachium, they're actually going to be attached to or connected to the lateral geniculate body, which for the thalamus subserve sensations to do with vision, right? This is another schematic of what we're describing. This is the opex, where you expect the floor to meet your rhomboid fossa. Then this is the dorsal median sulcus. Then you have the gracile tubercles, cuneate tubercles. Then you have the laterally placed tuberculum cinereum that is now as a result of the spinal trigeminal tract and its nucleus, of course, that will actually be representing the dorsolateral tract of Lissoir from the spinal cord, as well as the first four rex lamina of the spinal cord, right? Then this is your rhomboid fossa. Notice this is going to be the facial colliculus. There's the median sulcus, right? Then this region here, your locus coeruleus, it actually is comprised of noradrenergic fibers, right? And this is the vestibular area that is lateral to your sulcus limitans, which is this one, right? Then this is your vagal. Then this is your vagal trigone, which is this one. This is the vestibular. Then this is your hypoglossal trigone, which is as a result of the underlying hypoglossal nucleus, right? Then this, it's a brain section showing us the flow of the fourth ventricle, which is this one, right? And notice the presence of the lateral recesses that I mentioned in the cerebellopontine angles, your foramen luschka in this region. These are the inferior colliculi. These are the superior colliculi, right? This is the superior medullary velum in this region, right? This is your superior cerebellar peduncle. This is the mid to cerebellar peduncle. Then this is the inferior one attached to the medulla, of course, which is this, your medulla oblongata, right? Then moving further on now, looking at the internal surfaces of the brainstem. This is a transverse section at the level of the decussation of the pyramids, right? So in this region, you can notice the decussation of the pyramids in this region. This is the lower surface of the medulla, right? You're going to have 85% of the corticospinal fibers decussate in this region to come to the contralateral side, But you're going to find that when we describe the lesions of most of the midbrain and the pontine lesions that include the descending corticospinal fibers, it's going to actually result in contralateral hemiplegia because the fibers are going to come and cross and go to the contralateral side in this region. So this is the decussation of the pyramids, and this is the central canal. Right, the central canal actually being continuous, of course, with the fourth ventricle, and it's going to represent the lumen of the rest of the neural tube that did not form vesicles during embryonic life. It's actually going to be the central canal of the spinal cord. Right, and notice on the dorsal aspect, just as I mentioned earlier on, you have the nucleus gracilis, which is this one, and its associated bulge, which is the fasciculus gracilis that was forming that gracilis tubercle, right? Then lateral to this nucleus gracilis, you expect the nucleus cuneatus, which is this one. And more lateral, just lateral to the nucleus cuneatus, you expect to see an external or an accessory cuneate nucleus that is actually going to be subserving now fibers that are coming from the neck and the upper limbs, and it's going to function in a way similar to the dorsal spinocerebellar tracts that are carrying proprioceptive fibers. So these nucleus gracilis and the nucleus cuneatus, they're actually receiving the fibers that you find within the dorsal columns of the spinal cord that are carrying the finer sensations, and they're going to decussate. I'll show you that in the next slide. That is somewhere midway in the medulla, and they're going to form the medial lemniscus. So they form together, they form the dorsal column or the dorsal medial lemniscus pathway, right? Then this is the trigeminal tract and its nucleus. Remember, the nucleus will actually be just medial, and this is the tract, right? And you say they're going to form that tuberculum cinereum that we realized on the dorsal aspect of the brain. Then this is the medial longitudinal fasciculus. The medial longitudinal fasciculus will mainly be comprised of fibers that are coming from the medial vestibular nucleus, and it is what will continue downwards beyond your foramen magnum is the medial vestibulospinal tract that will end somewhere in the neck, whilst the lateral vestibulospinal tract will actually be coming from the lateral vestibular nucleus, which can alternatively refer to as your data's nucleus. Right. Then this yellow part here, this is your lateral spinothalamic tract. Remember, the spinothalamic tracts, they're actually going to be crossed fibers, and they're going to cross at the level of entrance at the spinal cord, or they're actually going to travel within that dorsolateral tract of Lesoir to cross to the contralateral side about 2 or 3 segments above or down, and they're going to be subserving pain and temperature sensations, right? Then the red and the green parts here, these are going to be your spinocerebellar tracts. So you have the anterior spinocerebellar tract, which is this one, and you have the posterior or the dorsal spinocerebellar tract, which is this one. The dorsal spinocerebellar tract will actually be originating from the Clark's column or the nucleus thoracicus in the thoracic region, whilst this anterior spinocerebellar tract will be originating in the lumbosacral region. Together, they will be carrying proprioceptive fibers. You're going to find that this dorsal spinocerebellar tract, you're only going to see it in transverse sections of the medulla because it's actually going to enter the cerebellum via the inferior cerebellar peduncle. Unlike this anterior spinocerebellar tract, which will actually enter the cerebellum via your superior cerebellar peduncle. So you're also going to see it in the midbrain as well as some parts of the pons. So basically the entire pons and parts of the midbrain before it actually enters the cerebellum via your superior cerebellar peduncle, right? So the medial lemniscus, I talked about it, it's actually going to carry the finer sensations. And if you look at the level of decussation of the medial lemniscus, notice these are the fibers that are actually coming from the nucleus gracilis, which is this one, and the nucleus cuneatus, which is this one. And their crossing fibers, they're going to form your internal arcuate fibers. Remember earlier on, I said the external arcuate fibers were actually fibers that were coming from the arcuate nucleus, and they're actually going to cross to go to the cerebellum. And those that nucleus, your arcuate nucleus, actually represents more or less a displaced pontine nuclei, because it's going to have the same connections with the pontine nuclei. Right. Then from this region, you can also see the inferior olivary nuclei, which are these ones. These inferior olivary nuclei, they're actually part of your pre-cerebellar nuclei, right? Then this is your medial longitudinal fasciculus. Alternatively, I will describe it with the pons. Then this is the hypoglossal nucleus, right? Then this is the central canal. Then this is the nucleus ambiguous. The nucleus ambiguous is going to give fibers to the cranial nerve number 9, 10, and 11. So it's actually going to supply structures going to be innervated by the pharyngeal plexus to include the palate, the pharynx, and so forth. Then this is still your spinocerebellar tract, and this is the spinothalamic tract, your lateral spinothalamic tract, right? Then from another view, this is your nucleus gracilis and the fasciculus. This is the nucleus, your nucleus cuneatus and its fasciculus. This is the accessory cuneate nucleus that we said was going to form the cuneo-cerebellar pathway to the cerebellum, subserving proprioception from the upper limbs, right? Then this is the nucleus of the spinal tract of the trigeminal of the trigeminal nerve and its laterally placed tract, which is this one. Then this is the nucleus ambiguous, which will actually be located within your reticular formation, and so it was going to give fibers to your muscles of the pharynx, the palate, whatsoever. So basically they're going to the glossopharyngeal, the vagus, and the accessory. And it's also going to give the parasympathetic fibers that are going to the heart, your cardiac ganglia. Remember, you have the superficial and the deep cardiac plexus, the superficial being just beneath the arc of the aorta, whilst the deep one will be at the level of the carina, that is at your sternal angle. They're going to receive the parasympathetic fibers from the nucleus ambiguous, whilst the more larger dorsal nucleus of the vagus rather, will actually innervate the rest of the parasympathetic fibers of the thorax, the foregut and the midgut, up to a level where you have the junction of the proximal 2/3 and the distal third of the transverse colon, right? Then this is your acute nucleus, which is this one, that we said was going to send projections to the cerebellum via the stria medullaris that we saw on the dorsal surface of the medulla, as well as the external arcuate fibers. The internal arcuate fibers, we say they're actually being formed by the decussating fibers that are coming from the nucleus gracilis and the nucleus cuneatus to form your medial lemnisci, which are these ones, right? Remember, these fibers will actually be going to dock at the level of the thalamus, right? Then this is still your inferior olivary nucleus. Then this is the vestibulospinal tract, which is descending, and it will end up being in the ventral funiculus of your spinal cord. Then this is the rubrospinal tract, which is carrying the fibers that decussate from the red nucleus. We'll talk about that with the midbrain. Then you'd find that the fibers that actually do not decussate, that are going to be coming from the red nucleus, the ipsilateral red nucleus, they'll come and dock at this inferior olivary nuclei, and they're actually going to form what is known as the central tegmental tract. That central tegmental tract will not only carry descending fibers, it will also carry some ascending fibers that will actually be coming from the nucleus of tractus solitarius that are subserving taste. Right? Then these are still your spinocerebellar tracts, the dorsal one and your ventral spinocerebellar tract. Then this is still the spinothalamic tract, right? Remember, you have a lateral spinothalamic tract, then you have a ventral one, right? Then this is your spinal olivary tract, just this one, because these inferior olivary nuclei, they will also be receiving fibers that are coming from all levels or all segments of the spinal cord. So you'd also expect to have a spinal olivary tract, right? Then if you look at this transverse section, that is our third one, when you're looking at the medulla, that is at the level of the olives now, you can appreciate the dorsal spinous cerebellar tract in this region actually entering this peduncle, which is your inferior cerebellar peduncle. And notice, as I said earlier on, this dorsal, or rather this inferior cerebellar peduncle, it's going to separate the dorsal and the ventral cochlear nuclei, right? And a lesion of these two nuclei above them, or just rostral to this nuclei, will not result in unilateral deafness, because if you look at the auditory pathway above this level, it will actually be bilateral, right? Then this is the solitary tract and its nucleus, right? Then this is the dorsal vagal nucleus, right? Then this is the hypoglossal nucleus, which is more medial. Then this is the medial longitudinal fasciculus. Basically, it'll be carrying fibers that will be working in your gaze, that is either the lateral gaze or the vertical gaze, the internuclear fibers that are actually coming from the nucleus of the abducens to go to either the contralateral side to effect the medial rectus for you to be able to have a lateral rectus, or to actually effect both the oculomotor and the trochlear nerve for the vertical gaze. Because remember, you're going to have your PPRF, your paramedian pontine reticular formation, that is going to be your lateral gaze center for the first one. Then the slow one will be affected by your nucleus prepostus hypoglossy. Then the vertical gaze center will actually be your interstitial nucleus of Cajal, right? Then these are still your rubrospinal tracts that are forming your ventral tegmental decussation in the midbrain. We'll talk about that in the midbrain. Then this is the lateral reticular nucleus in this region, right? Then this is the vestibulospinal tract that is coming from the lateral vestibular nucleus that we also refer to as the datus nuclei. And this will actually be going to affect mainly your anti-gravity muscles. And this is the nucleus ambiguous again. Then this is your acute nucleus, if you can see. This is the medial lemniscus. These are your pyramids, of course. That's you then refer to the descending corticospinal tract as your pyramidal tracts. Then this is the inferior olivary complex, right? And part of the inferior olivary complex, we said you see a pre-cerebellar nuclei, which is actually your inferior olivary nucleus, right? Then maybe to describe the nuclei that we find at this region, she said the more medially placed hypoglossal nucleus. This hypoglossal nucleus is actually going to innervate the muscles of the tongue, both the intrinsic and the extrinsic, except of course your palatal glossus. And you're going to find that initially the rootlets that will pass between the medial lemniscus, which is this one. So this is your medial lemniscus, right? So they will pass between the medial lemniscus and the inferior olivary nucleus. Remember, we said when they then emerge from the ventral surface of the medulla, they're going to lie between your pyramids and the olives, right? So these are the hypoglossal nuclei, right? Then the cochlear nuclei, you're going to have a ventral one and a dorsal one. The dorsal one will further be divided into a part that is more anterior and a part that is dorsal, where you'll be having emergence of the dorsal and the intermediate acoustic stria respectively. Then from the ventral one, you'd expect to have your trapezoid body, which is the ventral acoustic stria, right? Then also from this view, you can notice the presence of these accessory olivary nuclei, the dorsal one and You have the medial one. Then dorsal to this olivary complex, you expect to have this lateral reticular nucleus, which also has connections with the cerebellum, right? It's actually also going to be related to your spinal lemniscus, which is being formed, of course, from the spinothalamic and the spinotectal, right? Then, if you look at it from this kind of a view, right, these are going to be your pyramidal tracts. This is the medial lemniscus, right? This is the medial longitudinal fasciculus. Then this is the inferior olivary nucleus, the main one, or you can say the inferior olivary complex if you may want to call it. This is the inferior cerebellar peduncle. Right. This region you'd expect to see the spinal lemniscus. Right. So the blood supply for the medulla, it will actually come from branches of the vertebral as well as branches of the basilar artery. You're also going to see some paramedian branches that actually come from the anterior spinal artery, right? And some branches that come from pica, your posterior inferior cerebellar artery, which is the largest branch of the vertebral arteries. Then the venous drainage would be into the basilar venous plexus. You have the inferior petrosal sinus as well as the occipital sinus. And occlusions of these arteries will actually result in clinicals to include your medial medullary syndrome and your lateral medullary syndrome, right? So this is the site of the lesion if it's going to be a medial medullary syndrome. Right? You're actually going to transect the medial lemniscus as well as the pyramids and the hypoglossal nerve that we were saying its nucleus is actually medial, right? So this is your medial medullary syndrome. Notice ipsilaterally, you have paralysis of the tongue on the same side because you affect the hypoglossal nucleus. You're going to have tongue deviation. And contralaterally, you're going to have hemiplegia, that is cross pyramid damage, right? Then you're also going to have loss of touch and kinesthetic sense, your finer sensations on the opposite sides because you're affecting the medial lemniscus after you've had decussation of fibers from the cuneate and your gracile fasciculi, right? Then if it's a lateral medullary syndrome, commonly known as Wallenberg syndrome, different from the Waardenburg syndrome, that is an embryological defect due to neurocranial defects, you're going to affect the more lateral structures of the medulla. And notice you're going to take out the spinal nucleus and tract of the trigeminal nerve. You're going to lose the nucleus ambiguous. You're going to affect parts of the reticular formation as well as the lateral spinothalamic tract. So if you then look at what's going to happen, ipsilaterally, you're going to have loss of pain and temperature sensations on the face because you've affected the spinal tract of the trigeminal nerve. Then you're going to have a Horner's syndrome because you're going to affect the descending hypothalamo spinal fibers that are actually traversing the lateral aspects of the medulla. And those fibers, they're actually going to be carrying sympathetic fibers that are going to that thoracolumbar region for those lateral gray ones. And it's going to result in ptosis, meiosis, and anhidrosis. And you're going to have paralysis of the palate because you're going to affect the nucleus ambiguous, remember. You're also going to have laryngeal and pharyngeal paralysis, and you're also going to see nystagmus because if you look at this, right, notice the presence of the vestibular nucleus. It's also being affected in this region, right? Then contralaterally, that is below the neck, you're going to have loss of pain and temperature sensations in the trunks and the limbs because of affecting your lateral spinothalamic tracts. Then you're also going to see ovular deviation as well as a nystagmus. That is a rapid horizontal phase. Right. Then looking now at a transverse section in the lower pons, this is going to be the ventral aspect of the pons, the basilar aspect of the pons. And notice you're going to have pontine nuclei, right? Then you're going to have the descending corticospinal and the corticonuclear fibers in this region, right? Then you're going to have transverse fibers that are going to be decasseting in the midline to go to the mid-cerebellar peduncles, which are actually carrying efferent fibers to the cerebellum, right? And those this mid-cerebellar peduncle will only carry fibers that are going to the cerebellum, and those fibers will actually be mossy fibers. Most of the fibers that we were seeing in the inferior cerebellar peduncle that were coming from the inferior olivary nucleus, those fibers were actually going to be climbing fibers. Then so these are the corticospinal and the corticonuclear fibers. The corticonuclear or corticobulbar fibers are actually going to your cranial nerve nuclei. Then your corticospinal fibers, from this, they have not yet decassated. That is why earlier on I said, if you're then going to have a pontine lesion that is going to affect the basilar part of the pons or the ventral aspect of the pons, it's going to be characterized by having contralateral hemiplegia, because these are the very same fibers that are going to decassate in the lower levels of your medulla, right? Then the pontine nuclei will receive cortical fibers, your cortical pontine fibers. Then those pontine nuclei will then send fibers via the midcerebellar peduncle. So essentially, we can just say it's a cortical pontine cerebellar pathway, right? Then if you then look at the tegmentum of the pons, this is going to be the inferior cerebellar peduncle. And notice it's going to separate the dorsal cochlear nucleus and the ventral cochlear nucleus. This is still the ventral spinocerebellar tract. At this level, you no longer have the dorsal spinocerebellar tract because it has already entered the cerebellum via the inferior cerebellar peduncle, right? Then also in this region, you can now see the lateral lemniscus, which is this one, and its nucleus, right? The lateral lemniscus has a function in audition. So when you have fibers coming to synapse with the dorsal cochlear nucleus and the ventral cochlear nucleus, those from the ventral cochlear nucleus will cross to the contralateral side via this trapezoid body, right? And those synapse at the nucleus of the superior olivary, right? Those will be making your ventral acoustic stria. Then most of the fibers from the dorsal cochlear nucleus, they'll actually project to the nucleus of the lateral lemniscus. And the lateral lemniscus itself would then project to the inferior colliculus at the level of the lower midbrain, right? So this is the lateral lemniscus, right? And notice in this region here, right, you're having the trigeminal lemniscus that is being composed, of course, of the ventral and the dorsal trigeminal thalamic tracts, right? Then this here is going to be your medial lemniscus, right? So you have the medial lemniscus, then you have the trigeminal, then you have the spinal lemniscus, which is spinothalamic and spinotectal. Then you have the more laterally placed lateral lemniscus, which is this one, right? Then this is the central tegmental tract that we're saying is actually carrying fibers that are coming from the ipsilateral red nucleus, right? Then this is the rubrospinal tract. It's carrying fibers that are coming from the contralateral red nucleus of the midbrain. So they're actually going to decassate in the ventral tegmental decassation. And dorsal to them, you'd expect to see the tectospinal tract, which is carrying fibers that are coming from the superior colliculus. And those fibers, they're going to decassate, forming the dorsal tegmental decassation of the midbrain, right? Then this is still going to be your medial longitudinal bundle, right? And notice you're going to have the facial nucleus, which is this one, which is going to curve dorsomedially and form this internal genu around the abducens nucleus, and they're going to exit at the pontomedullary junction together, right? And remember, the facial nucleus will actually, or the facial nerve itself, it's going to supply the muscles of facial expression, meaning to say a lesion in this region can actually result in an ipsilateral facial paralysis that may also be accompanied with loss of pain from the ear, as well as loss of taste from the anterior two-thirds of the tongue, if you remember the chordae tympani nerve from your head and neck, right? Then this is the spinal nucleus, and the spinal tract of the trigeminal nucleus, which is this one, right? They're still present in the lower part of the pons, right? Then if you look at it from another view, which is this one, this is still the abducens being a more medial exit, having a more medial exit to the facial nerve, right? Then this is the medial lemniscus. This is the spinal lemniscus, right? Then this is your trapezoid body, composed of the ventral acoustic stria that is crossing to the contralateral superior olivary nucleus, right? Then this is still the spinal nucleus and the tract of the trigeminal nerve, right? These are the transverse fibers, your pontocerebellar fibers now that are now entering the cerebellum via the midbrain peduncle, right? Then on the dorsal aspect, this is the facial colliculus as a result of the underlying nucleus of the facial nerve. These are still your cochlear nuclei, the dorsal and the ventral cochlear nuclei, right? Then this is a transverse section in the upper part of the pons, right? Notice the ventral aspect is still the same, right? Then if you look at this is your lemnisci. This is the trapezoid body. So this is medial lemniscus. Then from the medial lemniscus, you'd expect to have trigeminal lemniscus, then spinal lemniscus. The lateral lemniscus, from this point onwards, it's a bit separated because it's now almost reaching its final destination, which is the inferior colliculus of the midbrain. And if you look at the arrangement in the spinal lemniscus, or rather in the medial lemniscus, you're going to have a twisting in such a way that initially the fibers in the spinal cord, they were actually having the fibers from the lower limbs or from the gracile nuclei that are going to the gracile nuclei rather being medial, than the cunate one being lateral. But as the medial lemniscus ascends, it's going to twist in such a way that the fibers from the lower limb will go lateral, those from the head and neck will go, rather those from the upper segments will actually go medial. So it's going to twist and it's going to have a somatotopic organization that is different from what you see at the lower levels of your medulla and even the spinal cord, right? This is still the rubrospinal tract. This is still your medial longitudinal bundle. This is the fourth ventricle, because remember the fourth ventricle, it's intimately related to the pons and the medulla, right? This is your ventral spinocerebellar tract. And from this view here, we can actually visualize this superior cerebellar peduncle. And this is the ventral spinocerebellar tract as it actually enters your cerebellum via the superior cerebellar peduncle, right? Then this is still the same, just that it's more of a schematic that is illustrating your medial longitudinal. Then you have the rubrospinal, you have the tectospinal in this region. This is the superior cerebellar peduncle. This is the main sensory nucleus of the trigeminal, which is found in the pons. And only if you look at the trigeminothalamic fibers, the ventral and the dorsal will be carrying only contralateral fibers, but the ventral one is both ipsilateral and dorsal, and they come only from this main sensory nucleus, or the pontine trigeminal nucleus, right? But then if you look at those that are going to the dorsal one, they'll be coming from all the nuclei of the trigeminal nerve, to include the mesencephalic nucleus that you're actually going to find within the midbrain. Because remember, we said the mesencephalon was going to be the midbrain. It's going to be carrying proprioceptive fibers from the head and neck, right? This is to your trapezoid body, right? The bluish line here, this is your mesencephalic root of the trigeminal nerve, right? And together, they are making this fasciculus, right? And it's going to exit as the trigeminal nerve on the lateral aspects of your pons. And within the trigeminal lemniscus, rather, you're going to have the ventral and the dorsal trigeminothalamic tracts that are actually now going to the thalamus, right? Because remember, The thalamus will be having the ventral-posterolateral subserving from the neck beyond down. Then the neck and the head, they're going to go to the ventral-posteromedial nucleus of the thalamus. Right. Then for clinicals now associated with the pons, right? You're going to have lesions maybe on the ventral aspect and lesions on the dorsal aspect, right? So this lesion that is going to be in this region, this is known as Raymonds Syndrome. It's a ventral pointing syndrome. And within this Raymonds Syndrome, you're going to find that in Raymonds Syndrome, what you affect is the sixth nerve, that is the abducens nerve, as well as the descending corticospinal fibers. So you're going to have contralateral hemiplegia, and you're going to have ipsilateral sixth nerve palsy, right? So you have contralateral hemiplegia and ipsilateral sixth nerve palsy. Then if you look at this one, it's still a ventral pointing syndrome. This is your Goblet syndrome. You're still going to have contralateral hemiplegia, but you're going to affect the facial nerve now. Meaning to say you're going to have ipsilateral facial nerve palsy. You're going to have drooping of the side on that on the side of the lesion of the face. And you're going to have loss of lacrimation and salivation, as well as secretions of the nasal glands. Then you're also going to lose taste sensations on the anterior 2/3 of the time due to the effect of the coda tympani nerve. Right. Then you're going to lose pain, touch, and temperature sensations from the external ear. Right. This is your Goblet syndrome. Right. Explained maybe in this slide. These are occlusions of the paramedian branches of the basilar artery. Because remember, the basilar artery is the artery that will actually mainly supply the pons as it travels in that basilar sulcus. Right. Then you have what is known as Fourville Syndrome. Fourville Syndrome now will include both the facial nerve and the abducens nerve, and you're also going to have contralateral hemiplegia. On top of that, you're going to affect the paramedian pontine reticular formation. And this paramedian pontine reticular formation, if you revisit your visual neuroanatomy, that paramedian pontine reticular formation, it's going to be the lateral gaze center. So you're going to have ipsilateral gaze palsy, right? For example, if you affect this side, let's say you affect this side, that was supposed to send maybe fibers to the lateral, or let's say the abducens, and that abducens was supposed to activate the lateral rectus of this side for it to look this side. Then it was also supposed to cross via the medial longitudinal fasciculus and go to the medial rectus of the side to actually the subnucleus of the oculomotor that subserves the medial rectus of the side for it to look medially. Then you have your gaze being directed in one side, but you're going to affect gaze towards that side if you actually lose that paramedian pontine reticular formation. So that's going to be Fourville syndrome. Then you have something known as lateral pointing syndrome, or your Murray-Fox syndrome. And this will mainly involve the corticospinal and the corticobulbar fibers, but it also includes the spinal lemniscus, which carries fibers for pain, temperature, crude touch, and pressure. So you're also going to lose that. And you may have development of what is known as a locked-in syndrome, which is basically a bilateral pointing lesion that primarily affects the ventral aspect. So you're going to lose everything except the reticular formation. So these people will still be conscious and aware, and they won't be able to move anything except their eyes, right? And these people, they have what is known as bilateral internuclear ophthalmoplegia with horizontal gaze palsy, right? But you're going to find that the vertical gaze will actually still be intact. Right? So since you have the reticular formation, you're consciously aware of everything that is happening to you, right? But you can't move, you can't talk because everything has been lesioned. Right? So that's a locked-in syndrome. Then if you look at the region of the midbrain, this is going to be your transverse section through the inferior colliculus, at the level of the inferior colliculus. So notice you now have the medial lemniscus, trigeminal and the spinal, the lateral lemniscus is now entering into the inferior colliculus. Right. And this is the substantia nigra that is in the tegmental part of the midbrain, and it's going to be present in all levels of the midbrain. This substantia nigra, which is this one rather. Right. It's going to be divided into a pars compacta and a pars reticularis. The pars reticularis will more or less function like the globus pallidus internus, and the pars compacta will be having dopaminergic projections to the striatum. With those that are going to synapse at D1 being excitatory, and those that are going to synapse at D2 receptors actually being inhibitory, because the fibers that are going to those receptors, you find that the D2 receptors, they're actually serpentine G-coupled metabotropic receptors that are coupled to your GI, which is your G inhibitory, right? Then at this level, you can see the inferior colliculus, which is this one. The inferior colliculus is actually going to be working in the auditory pathway, right? Which is this one, right? Then if you look at a transverse section just above, this will be your superior colliculi. The superior colliculi will be working in the visual pathway, and actually find that the cytoarchitecture of this superior colliculus will actually be having about 7 layers, right? Then together, those two, your corpora quadrigemina, they will make up the tectum, right? Notice this is the cerebral aqueduct. Then this is gray matter making up your periaqueductal gray matter. This is the mesencephalic nucleus of the trigeminal nerve, subserving proprioception for the head and neck, right? This is your medial longitudinal fasciculus. We've talked about it, right? Then the red one, it's your trochlear nucleus, right? Because remember, the trochlea is going to emerge on the dorsal aspect of the midbrain at the level of the inferior colliculus, right? Then this is the tectospinal tract. We'll see the tectospinal tract as it decussates at the level of the superior colliculus. Then this is going to be the decussation of the superior cerebellar peduncle, which you find at the level of the inferior colliculus, meaning to say it's actually going to be found where, rather that's where you're going to have your superior cerebellar peduncle entering your cerebellum at this level. And that's also where you'd expect to have the anterior or the ventral spinal cerebellar tract now entering into your superior cerebellar peduncles. Then this is your crus cerebri, right? Notice you're going to have the frontal pontine fibers occupying the medial 1/5. Then the mid with 3/5, they have corticospinal and corticonuclear fibers. Then the lateral 1/5, there's temporal pontine, parietal pontine, and occipital pontine. And the corticospinal fibers in this region, they're going to be arranged in a homunculus in this way, with the head region actually being more medial, the arm region being in the middle, then the leg being the most lateral, right? Then this is the central tegmental tract. It's coming from the ipsilateral red nucleus, which we'll then see from this level of the superior colliculus. This would be the red nuclei, and the red nuclei, they're going to form have fibers decussate and cross the midline in this bluish ventral tegmental decussation to form the rubrospinal tract. Then tectospinal fibers, they're going to cross in this dorsal tegmental decussation, and they'll course downwards as the tectospinal fibers. They'll be coming from the superior colliculus. That is why you can actually turn your head or your neck in the direction of a visual stimulus, right? Then this is the central tegmental tract, which we are saying is actually coming from an ipsilateral red nucleus. This is still the medial lemniscus, trigeminal lemniscus, and the lateral spinothalamic. You're still going to see them at this level because you haven't reached the thalamus where they're going to dock. Then these are your pretectal nuclei. The pretectal nuclei, you actually have communications with the Edinger-Westphal nucleus that is going to be working in the parasympathetic system. right? Then this is still your cerebral aqueduct joining the third ventricle to the fourth ventricle. Because remember, we said the lumen of the mesencephalon was going to form the cerebral aqueduct, right? Then at this level, you can also see the main nucleus of the oculomotor. Because remember, I said the oculomotor nerve was going to exit on the lateral aspect of the interpeduncular fossa, and it was going to cause between the terminal branches of your basilar artery, that is the superior cerebellar artery as well as the posterior cerebellar artery. Then it was going to course forwards in relation to the posterior communicating artery. That is, of course, a branch of that posterior cerebral artery as well. Right. Then this is still the substantia nigra having a pars compacta and a pars reticulata. Then this is your crus, right? Then this is the inferior brachium in this region. Right? The inferior brachium, of course, is now going towards the medial geniculate body of the thalamus from the inferior colliculus. The one that comes from the superior colliculus, that will be the brachium of the superior colliculus, or you can refer to it as the superior brachium. Then if you look at the pretectal nuclei, they're the ones that actually work in subserving the direct consensual light response. If you shine light in one eye, the other one will also constrict. Right? Then if you look at lesions of the midbrain now, in conclusion, you have what is known as Weber's syndrome. If you look at the diagram that is more on the right side, you can appreciate that this is a lesion in the ventral aspect, right? Particularly the medial aspect of the midbrain, right? And you're going to affect the oculomotor nerve. So you're going to have a third nerve palsy. And if you're going to have a third nerve palsy, you're also going to damage the medial aspect of the frontal pontine fibers as well as the corticospinal fibers. So you're going to mainly affect the head regions or the upper regions, because remember that on nucleus that I showed you, right? So you're going to have your pupils dilating due to that oculomotor nerve palsy, because remember the parasympathetic for you to allow for pupil constriction is actually coming from the Edinger-Westphal nucleus, which is going to be sending its fibers via that oculomotor nerve. Then you have what is known as Benedict syndrome, which is basically your paramedian midbrain syndrome. And in this syndrome, you're going to include the red nucleus. So you're going to have an ipsilateral third nerve palsy. Then you're going to have a contralateral cerebellar ataxia, due to the fact that you're going to find that the superior cerebellar peduncle, it's going to decassate at the level of your inferior colliculus. Then from the inferior colliculus, those fibers will then go to the contralateral red nucleus, which will then project to the cerebral cortex. Right. So that will be Benedict syndrome. You now include your you now include the red nucleus, and that will present as a contralateral cerebellar ataxia. You're going to have an ataxic gait, right? Then you can also have a posterior cerebral artery stroke, right? You can also have a posterior cerebral artery stroke that will have Weber's syndrome, Benedict syndrome, then Claude syndrome in this region. Claude syndrome, you're going to have contralateral ataxia. So the lesion is more at the red nucleus, but you may also include the third nerve, which is your oculomotor nerve. Right. Then you have what is known as Peynaud syndrome. This is when in cases of having a pinealoma or a pineal tumor, it may actually compress the superior colliculus. And if you compress the superior colliculus, you may actually affect as well as the pretectal nucleus, as well as the interstitial cells of Cajal, which is basically your vertical gaze center. So you're going to have problems with vertical gaze, but the lateral gaze is actually going to be maintained, because that is being affected by your nucleus prepositus hypoglossy, as well as your PPRF, which is your paramedian pontine reticular formation, right? Then on top of that, you're also going to see that you may have bilateral lid retraction, right, due to the levator palpebrae superioris being affected, because the levator palpebrae superioris muscle, it will actually be innervated by the oculomotor nerve as well, right? Then you'd find that the superior rectus and your inferior rectus, they will cause retraction of the eye, because those muscles will still be intact. And so they're going to cause retraction of the eye, right? And that will now be called lid retraction or Collier sign, which you're seeing from the picture in this view. Right. Then you're also going to lose the pupillary light response, as well as what happens is you lose the pupillary light response, but you maintain accommodation, because so you'd find that for the eyes to actually accommodate, they're still going to be able to accommodate, but you'd find that the pupillary light response is actually going to be lost, because you're going to depend on the pretectal nuclei now, and those pretectal nuclei have been affected. But the Edinger-Westphal, which is your parasympathetic nucleus, it's still intact, so you can still have convergence, right? Then this will now be called your Agile-Robertson people, where you can actually have the light near dissociation. Right, so that's just about it.